Gain a deeper understanding of the nuances of MSK imaging across all life stages. Join RSNA in Lima, Peru, January 23rd through 24th for MSK a través de las edades de la pediatría a la geriatría. This 2-day bilingual course delivers interactive, hands-on learning to help you discover practical tools for the diagnosis and management of MSK conditions you can immediately apply to your clinical practice. Register today at rsna.org/spotlightlima.
Hello, greetings from San Antonio, Texas. My name is Dr. Venkata Katabathina and I serve as the Section Director of Abdominal Imaging and Vice Chair of Education in the Department of Radiology at UT Health San Antonio. I'll be discussing our recent article in Radiographics, current update on nomenclature, diagnosis and management of metabolic dysfunction associated steatotic liver disease, radiologist perspective. Metabolic dysfunction associated steatotic liver disease, MASLD, is a new name for non-alcoholic fatty liver disease, NAFLD. MASLD is the most common cause of both steatotic liver disease, SLD, and chronic liver disease worldwide. The American Association for the Study of the Liver Diseases, AASLD, published practice guidance in 2023 to incorporate changes in the diagnosis and management. A new nomenclature for MASLD with updated definitions has been approved. AASLD practice guidelines on blood-based and imaging-based non-invasive liver disease assessments of hepatic fibrosis and steatosis have also been recently published. The latest advances in ultrasound and MRI techniques have allowed radiologists to play a major role in early detection, accurate assessment, and monitoring of MASLD. Resmetirom has recently been approved for treating non-cirrhotic adult patients with MASLD and moderate to severe hepatic fibrosis along with diet and exercise. In this article, we'll review the role of imaging in the new guidelines as the current evaluation of MASLD is changing from invasive tests to advanced imaging-based diagnostics. This article will serve as a reference for the radiologists who play a critical role in the management of MASLD. New nomenclature for steatotic liver disease. SLD, steatotic liver disease, is the new adopted term replacing fatty liver disease. SLD is an umbrella term that includes individuals with hepatic steatosis diagnosed with histologic analysis or imaging due to various causes. The diagnosis of MASLD is made if a patient with SLD meets at least one of 5 cardiometabolic criteria, including obesity, insulin resistance, hypertension, elevated triglyceride levels, or low HDL cholesterol levels. A new category, MASLD and increased alcohol intake, MASLD, describes individuals with MASLD who also consume significant amounts of alcohol. Other subgroups of SLD include alcohol-associated liver disease, specific causes such as drug-induced or genetic diseases, miscellaneous conditions, and cryptogenic SLD without any identifiable cause. Given this significant overlap, ongoing research on biomarkers, drug development, and natural history studies will remain unaffected, and all recommendations from the AASLD on blood-based and imaging-based biomarkers for NAFLD are fully applicable to MASLD. The new terminology provides a cause-based diagnosis and enables clinicians to explain MASLD to patients without relying on potentially stigmatizing language. Increasing awareness of the metabolic origins of MASLD will assist primary care physicians in identifying more patients at an earlier stage, while hepatologists may better recognize those requiring treatment. MASLD disease spectrum, current update on pathophysiology and natural history. The clinicopathologic spectrum of MASLD includes metabolic dysfunction associated steatotic liver, MASL, MASH, and cirrhosis. MASL is defined as macrovesicular steatosis without inflammation, while MASH includes macrovesicular steatosis associated with hepatocyte injury and inflammation with or without fibrosis. Cirrhosis is characterized by bands of fibrosis and formation of regenerative nodules. The Metavid scoring system is the most commonly used histopathologic classification system for hepatic fibrosis. The Metavid system assesses hepatic fibrosis level, which ranges from no fibrosis to stages 1 to 4 based on pathologic findings. The AASLD recently simplified fibrosis stages into 3 categories that include at least significant fibrosis, stages 2 to 4, at least advanced fibrosis, stages 3 to 4, and cirrhosis, stage 4. At-risk MASH is a new term introduced by the AASLD that describes patients with MASH with high histologic activity and a minimum of stage 2 fibrosis. These patients carry an elevated risk of developing liver-related morbidity and mortality. Non-invasive biomarkers are emerging as valuable tools for predicting hepatic steatosis, hepatic fibrosis, and adverse liver-related outcomes. Validation of non-invasive biomarkers will facilitate diagnosis of patients with significant or advanced fibrosis and evaluate their response to treatment without the need for liver biopsies. Clinical evaluation and management of MASLD, role of blood-based and imaging-based tests. The initial step is identifying patients with potential or established MASLD using imaging and clinical indicators such as incidental transaminitis, hepatic steatosis at imaging, or cardiometabolic risk factors, and performing initial fibrosis scoring. The AASLD recommends using fibrosis 4 score as the primary risk stratification tool to assess advanced fibrosis. Patients with fibrosis 4 score greater than 2.67 are likely to have at-risk MASH or advanced fibrosis. They are referred to a hepatology or gastroenterology practice and may consider additional risk stratification. Patients with fibrosis 4 score between 1.3 and 2.67 will undergo secondary risk stratification with transient elastography or ultrasound-based elastography or with blood-based tests. Imaging techniques for assessing MASLD. Ultrasound-based imaging techniques include conventional grayscale ultrasound, fibroscan, which is also known as vibration-controlled transient elastography, VCTE, and shear wave elastography. While the controlled attenuation parameter, CAP, obtained from VCTE assess hepatic steatosis, the liver stiffness measurements, LSM, obtained from VCTE or shear wave elastography assesses hepatic fibrosis. The MRI proton density fat fraction, MRI PDFF, is a highly accurate non-invasive method for quantifying hepatic steatosis, and LSM values from MR elastography help to estimate hepatic fibrosis. MR spectroscopy is also helpful in assessing hepatic steatosis. Non-enhanced CT aids in the initial assessment and stratification of incidentally discovered hepatic steatosis. Hepatic steatosis, imaging-based identification and quantification. A cost-effective two-step screening strategy using VCTE followed by MR is suggested by the AASLD. Conventional B-mode ultrasound is often the initial study performed to evaluate the findings of elevated liver test results of unknown cause. Grayscale ultrasound allows classification of steatosis into 3 grades using the conventional ultrasound score. Ultrasound does not allow reliable differentiation between hepatic steatosis and fibrosis due to their similar echogenicity. Transient elastography, fibroscan, allows quantification of hepatic steatosis by measuring the ultrasound signal attenuation through the liver. The AASLD recommends transient elastography as the first-line screening to detect at least grade 1 steatosis at a CAP threshold of 275 decibels per meter. MRI PDFF is reference standard for non-invasive liver fat assessment. It has excellent histologic correlation for detecting and grading hepatic steatosis. MRI PDFF grades hepatic steatosis based on the percentage of hepatocytes affected by fat into mild 6% to 17%, moderate 17% to 22%, and severe greater than 22%. Non-contrast CT can be used to diagnose hepatic steatosis if any of the following are present: liver attenuation less than 10 Hounsfield units compared with that of the spleen, liver to splenic Hounsfield unit ratio less than 0.8, or liver attenuation less than 40 Hounsfield units. Moderate steatosis, defined as an MRI PDFF of 15%, corresponds to a hepatic attenuation of 40 Hounsfield units at non-contrast CT. Identification of hepatic steatosis, clinical significance. Approximately 20% of patients with MASLD progress from hepatic steatosis to advanced fibrosis, and those with MRI PDFF greater than 15.7% are at significantly higher risk of fibrosis progression. Conversely, a reduction of 30% or more from baseline correlates with a favorable histological response and potential fibrosis regression. MASH with advanced fibrosis can manifest with reduced or absent hepatic steatosis, also known as burned out MASH. A progressive decrease in liver fat in patients with advanced fibrosis or cirrhosis is associated with an increased incidence of liver-related events. Hepatic fibrosis, imaging-based identification and quantification. Hepatologists commonly used VCTE for fibrosis assessment and monitoring. Radiologists play a key role in advanced imaging for comprehensive fibrosis assessment, including shear wave elastography, MR elastography, and corrected T1 mapping. The AASLD recommends a stepwise approach that integrates imaging and blood-based non-invasive tests for comprehensive fibrosis staging and management. Ultrasound-based elastography. VCTE is a validated tool for quantifying liver fibrosis with good reproducibility. However, VCTE is unreliable in patients with ascites, obesity, and other confounding factors. Acoustic radiation force impulse techniques include point shear wave elastography and 2D shear wave elastography. MR elastography. MR elastography evaluates a large portion of the liver to assess liver stiffness by calculating the elastic modulus, typically ranging from 0 to 20 kilopascals. The AASLD recommends using ultrasound elastography or MR elastography to detect hepatic fibrosis and cirrhosis, and suggests that imaging-based techniques to be incorporated into the initial fibrosis staging along with the blood-based tests. At-risk MASH, role of imaging in identification. As there is an increased risk of developing significant disease burden and irreversible fibrosis, early detection of at-risk MASH, also known as active fibrotic MASH, is important to halt or reverse fibrosis on time. Emerging imaging biomarkers like corrected T1 mapping and combined imaging and serum-based scores like FibroScan AST score, MRI AST score, and MR elastography fibrosis 4 index are under evaluation for identifying at-risk MASH, but current evidence is insufficient for routine clinical use. FAST score is calculated using the transient elastography liver stiffness measurement, transient elastography controlled attenuation parameter, and serum AST values. It uses a rule-out cutoff of less than 0.35 and a rule-in cutoff of more than 0.67, offering excellent sensitivity for ruling out at-risk MASH. The FAST score addresses the increasing prevalence of MASLD, offering a rapid, cost-effective method for fibrosis screening without the risk of liver biopsy. MASH score. The MASH score derived from MR elastography liver stiffness measurement, MRI PDFF, and serum AST level also assists in detecting at-risk MASH. A retrospective analysis found a strong correlation between MASH scores and adverse liver outcomes. ME-Fib index. The ME-Fib index combines MR elastography liver stiffness measurement and fibrosis 4 score to detect at-risk MASH in patients with a fibrosis score greater than 1.6, followed by an MR elastography liver stiffness measurements greater than 3.3 kPa. The ME-Fib index allows identification of patients with MASLD who are potential candidates for pharmacologic therapy. Corrected T1 mapping standardizes measurements across magnetic field strengths, manufacturers, and iron levels, offering a reliable marker for fibrosis and inflammation. Corrected T1 mapping correlates with fibroinflammatory activity in the liver and can assess at-risk MASH. Corrected T1 mapping changes also reflect treatment-induced histologic improvement, making it valuable for evaluating intervention efficacy. Advanced fibrosis, role of imaging in detection. The 2024 AASLD practice guidelines recommend tests with thresholds such as transient elastography, shear wave elastography, and MR elastography based liver stiffness measurements to identify advanced fibrosis. The current AASLD algorithm suggests that patients with fibrosis for score greater than 2.67 combined with ultrasound elastography liver stiffness measurement greater than 12 kilopascal or MR elastography greater than 3.6 kilopascals are likely to have advanced fibrosis. The AASLD practice guidelines recommend using an MR elastography liver stiffness measurement cutoff of 3.6 to 4.6 for advanced fibrosis. An update from the Society of Radiologists and Ultrasound consensus statement provided guidelines for liver stiffness values for diagnosing compensated advanced chronic liver disease, including advanced fibrosis and cirrhosis. This guideline suggests a lower cutoff for shear wave elastography liver stiffness measurement of less than 9 kPa to rule out compensated advanced chronic liver disease in the absence of known clinical signs, and an upper cutoff for shear wave elastography LSM of greater than 13.0 kPa to rule in compensated advanced chronic liver disease. Cirrhosis, role of imaging in detection. The key imaging findings of cirrhosis and portal hypertension include coarse heterogeneous nodular liver, surface nodularity, splenomegaly, dilated portosystemic collaterals, and ascites. A fibrosis for score of greater than 3.48 and transient elastography LSM of greater than 20 kPa have 95% specificity for diagnosing cirrhosis, whereas a fibrosis score greater than 4.63 and transient elastography LSM greater than 28 have a 98% specificity for diagnosing cirrhotic liver. Individuals with moderate risk for advanced fibrosis are diagnosed with cirrhosis if subsequent elastography shows ultrasound LSM greater than 15 kPa or an MR elastography LSM greater than 4.7 kPa. Individuals with high risk for advanced fibrosis with fibrosis for score greater than 2.67 may be diagnosed with advanced fibrosis or cirrhosis starting at ultrasound LSM greater than 12 kPa or MR elastography LSM greater than 3.6 kPa. As per Society of Radiologists and Ultrasound consensus guidelines, shear wave elastography LSM greater than 17 kPa suggests advanced liver disease with clinically significant portal hypertension. Evolving role of CT in assessing hepatic fibrosis and cirrhosis. CT manifestations of cirrhosis such as surface nodularity, fissural widening, and segmental redistribution are well recognized. The liver surface nodularity score and hepatosplenic volume assessment are particularly noteworthy among CT-based biomarkers for allowing identification of early fibrosis stages. Ultrasound-based and MRI-based elastography methods in assessing hepatic fibrosis and cirrhosis. What is best? LSM using transient elastography, shear wave elastography, and MR elastography demonstrates acceptable to excellent accuracy in detecting liver fibrosis in MASLD, with performance improving as fibrosis progresses from significant to advanced and cirrhosis. However, the AASLD could not definitely confirm the superior accuracy of one method over another due to limited data. Current evidence suggests that imaging-based non-invasive tests are beneficial for identifying disease greater than stage 3 fibrosis. However, further research is needed to determine their relative performance across the full spectrum of MASLD and MASH. Management of MASLD. Management strategies for MASLD range from lifestyle changes to potential pharmacologic treatments. A healthy diet and regular exercise are foundation for treating MASLD. For individuals with overweight or obesity, a 5% or greater weight loss reduces hepatic steatosis, while a 7% to 10% weight loss is necessary to improve MASH and fibrosis. Good glycemic control helps to slow liver disease progression in patients with diabetes, and bariatric interventions or GLP-1 receptor agonists are advised for patients with obesity. Liver-specific pharmacologic treatment. On March 14, 2024, resmetirom, an orally active thyroid hormone receptor agonist, received FDA conditional approval in the United States for treating patients with non-cirrhotic MASH and moderate to severe fibrosis. Resmetirom selectively activates the liver-specific beta-1 subtype of the thyroid hormone receptor, reducing hepatic steatosis and inflammation by promoting lipophagy and mitochondrial biogenesis while inhibiting lipogenesis. Expert panel recommendations have been published with practical clinical applications for initiating and monitoring resmetirom treatment, with emphasis on the role of non-invasive tests. Eligible patients with at-risk MASH include those with MASH with stage 2 or 3 fibrosis at biopsy, if available, transient elastography LSM between 10 to 15 kPa, MR elastography LSM between 3.3 to 4.2 kPa, or fast, MAST, or MAFib values indicative of at-risk MASH, along with platelet count greater than 140 and no evidence of portal hypertension. MASH patients with transient elastography LSM between 15.1 to 19.9 kPa, or MR elastography LSM between 4.3 to 4.9 kPa may be still considered for resmetirom treatment with a platelet count greater than 140 and no evidence of portal hypertension, but with extra caution to rule out cirrhosis. Patients with advanced disease with cirrhosis and early disease are excluded from treatment. Longitudinal imaging biomarkers in MASLD, monitoring disease progression and treatment response. Longitudinal imaging and blood-based biomarkers are critical for tracking MASLD progression and assessing response to treatment, particularly for evaluating changes in steatosis and fibrosis. Improvement in serum ALT levels greater than 17 international units per liter decline, or reduction in hepatic fat content greater than 30% decline at MRI-PDFF could be used as surrogate markers for histologic improvements in MASLD. Improvement in fibrosis 4 score, transient elastography LSM or MR elastography LSM, FAST score, blood tests, and other biomarkers correlated with histologic fibrosis reduction in multiple studies. The AASLD advises against using imaging-based non-invasive tests alone to assess fibrosis regression or progression. Instead, changes in liver stiffness should be interpreted in the context of individualized treatment plan and clinical course. Treatment response assessment after resmetirom therapy should ideally be done at the 12-month point using ALT levels, transient elastography LSM, and MRI-PDFF. ALT decline of greater than 17 international units per liter or greater than 20% from the baseline value, or the complete normalization indicates a positive treatment response. Transient elastography LSM greater than 30% drop or MRI-PDFF greater than 30% drop in liver fat also suggests a positive treatment response, and continued treatment with resmetirom is indicated. Future directions. Future radiology research will likely focus on refining non-invasive tests for diagnosis, monitoring, prognosis, and therapeutic response across the MASLD spectrum. For example, there is a need to test whether improvements in non-invasive tests align with histologic changes and clinical outcomes, and to evaluate personalized hepatocellular carcinoma surveillance strategies in MASLD. Advanced imaging methods such as 3D MR elastography are promising. 3D MR elastography offers advantages over 2D MR elastography by evaluating a larger liver volume, demonstrating subtle changes in liver stiffness, and calculating additional biomarkers. Multi-parametric models combining ultrasound with blood tests have demonstrated substantial predictive accuracy for MASH. Conclusion. This radiographics article highlights the updated role of imaging techniques in diagnosing and managing MASLD and its progression. The new nomenclature of fatty liver disease aims to provide a holistic view of the disease pathophysiology, emphasizing the significant role of metabolic dysfunction and avoid stigmatization. The 2023 AASLD practice guidance and 2024 AASLD practice guidelines offer key updates on diagnosis, treatment, and monitoring of MASLD, emphasizing the metabolic aspects of the pathogenesis. The AASLD guidelines support integrating imaging modalities with clinical practice and advocate for a shift towards non-invasive testing. Adopting imaging techniques for diagnosis and management represents a transformative shift, promising better patient outcomes through more precise, less invasive diagnostic tools. I want to thank you for your time. Hope you learned about some clinical and imaging updates on metabolic dysfunction associated steatotic liver disease. Thank you so much.